actually we're going to be looking at 5 indicators, but one indicator has to do with communication. 2 indicators have to do with signs and symptoms, behaviors, I'm sorry. And then 2 indicators have to do with depression indicators as well. So we're looking at communication, behaviors, and indicators of depression. Now, the communication indicator looks at percent of residents who worsened with respect to communication, and then percent of residents who improved with respect to their communication abilities. It also is going to look at the behaviors for those that have worsened behavioral symptoms and those who have improved behavioral symptoms. And then under the mood indicators, which come from section E1, we're going to look at those people who have had a decline in their mood. So mood has worsened for those individuals. We're not looking at improvement in mood, just these 5 indicators. We've discussed this many times, but once again, we have prevalence indicators. None of the indicators today are of the prevalence type. That's where we use the one assessment. 2 of the indicators are, all 3 of the indicators are going to look at decline today. And then 2 of the indicators are going to be looking at improvement as well as decline. So those are the incident type indicators. Recall that all assessments will be removed from the study if those assessments, right, are 92 days or less from the admission date. So you've got to be in the system for 93 days or more. If it's the initial full assessment, that 14-day assessment, that will also be excluded. And recall that if we have more than one assessment done in a quarter, only the very last assessment is used for calculating the quality indicators, which is not the same for the RUGs, right? So when we calculate RUGs, we're calculating RUGs on every assessment that's in the system. But for the QIs, we only calculate on one assessment per quarter, and it's always the last assessment. When it's an incident indicator and we have 2 assessments that we have to look at, the first 3 exclusions are identical as for the prevalence indicators, except for we have this 4th one where that prior assessment has to be at least 45 days ago or more, but it cannot be any more than 165 days ago, or those assessments would be excluded as well. We're still talking about population risk adjustments, which we'll cover on another day. We talked about the rolling 4 quarters several times, the fact that it's always 12 months of data whenever you get a report from CIHI, or if you look at a quarter on the Health Quality Ontario webpage. So it may say that it's Q1 2014, as in this example, but you can see that the 3 quarters of data, or 9 months in 2013, are still being calculated as part of the statistic in 2014. And the only difference between the prevalence indicators and the incident indicators is that we have to have this 5th quarter in the analysis so that this quarter can look back at that quarter. So there's actually 5 quarters involved, but the data used in the calculation is only from these 4 quarters. And that's what CIHI refers to when they say rolling average. We're not looking at any prevalence indicators today. We're finished with all of the 12 prevalence indicators. We are looking at 2 indicators related to improvement. That's the behavioral symptoms and then the communication. And we're looking at 3 indicators on the where it's a decline. So worsen behavior, worsen communication, and worsen mood. So those are all the indicators that we're looking at today. There are only 3 of them, but for the behaviors and communication and mood, we calculate the decline as well. Now remember this table, this is where we're looking at Health Quality Ontario benchmarks. We're looking at the most recent data published for Ontario. And we're looking at Carol Esterbrook's paper where they came up with quality indicators that nursing care actually has an impact on. And Carol Esterbrook came up with 13 different indicators that nursing care could have an impact on. And we see from the quality indicators that we're looking at today, the worsened behaviors and the worsened mood. Both of those are part of the Carol Esterbrook top 13. You can see the behaviors are the 7th most easiest for us to have an impact on, and worsened mood is the 12, well, let's just say 12 because there's 2 12s because they came out as a tie. Weight loss and worsened mood, but let's say these are either tied for 12th place or they're tied for 13th place, however we want to look at that. Okay. Now behaviors also have risk indicators, and mood also has a risk indicator, and we'll be looking at the RAPs as we get to near the end of the presentation, and there you will also see that they're part of the CAPs as well. So both RAPs and CAPs, and then finally we're going to look at how they impact funding. So we can see that every one of the items today will have some impact on the funding or the RUGS model. Whereas we've seen in the past that some of the items do not. Now currently Ontario, most recent I should say, average is 13.5% of residents experience a worsened level of behavioral symptoms. So behavioral symptoms decline. And you can see the goal that's set for Health Quality Ontario is 8%. So there's still some way to go there to experience that other 5.4% that we're looking at to reduce that. However, on the mood items, it's saying here that mood or symptoms of depression, currently we see a decline for 24% of the residents. And that's pretty striking to me in a lot of ways. But if we can think of the implication, you know, all those E1 items, and that we're experiencing a decline across those. Not all the E1 items, I'm sorry. We're going to actually be looking at a scale called the Depression Rating Scale. And so it uses, I believe, 7 items from that scale. And we can see we want to get from 24% of residents, or nearly a quarter of all residents, have experienced a decline. And we're trying to get down to where it's 13%. Okay. So let's look at exclusions now. Now we know we have up to 4 exclusions for every single assessment is judged by those 4 that we talked about when we first started. But at the item level, at the quality indicator level, we can see that the communication score will see an exclusion for any people who have end-stage disease, require hospice, or in a coma. So they will not be included in the calculation if one of those 3 factors are yes, or all, one or all of them. And here we can also see for communication, when we're looking at the worsened communication, if on the previous assessment you added those 2 items up, making self-understood and understanding others, the total score, the maximum score, would be a 6. And here they're saying that if on the previous assessment you're already a 6, then obviously you can't get worse than a 6. So you would be excluded from the study. And then for the improvement, of course, the opposite. Again, on the previous assessment, we calculate making self-understood and understanding others. And if on that previous assessment your score was a 0, well, you can't get better than 0 or totally independent on those two scales. So you will be excluded from the study again. And that's something I want to point out time after time after time, is the fact that these quality indicators have so many restrictions, that is through exclusions, that many people will not be included in the calculation. They could be having a problem, but they won't be included just simply because of some exclusion factor. And that's why I like the 24 quality indicators, because we're not subject to leaving so many of the population out when we're doing these calculations. So let's go on to exclusions related to behaviors. And you can see that comatose is yes, so you would be excluded. However, the other two general exclusions, end stage and hospice, are not exclusion factors for the behavioral. And you can see here we're looking at for the behaviors on the worsened and the behaviors on the improvement. There are no independent exclusions for those, okay? And you can see these are the behavioral items that we'll be looking at: wandering, verbal abuse, physical. Now on the mood, where we're looking at a worsened, we're looking here at comatose individuals being excluded, but hospice and end-stage disease are not. Okay. On the previous, you can see here your depression rating scale is based upon the negative statements from E1, anger with self or others, unrealistic fears, health complaints, other types of complaints, sad, pained, or worried facial expressions, and crying or tearfulness. And remember, this is part of that depression rating scale, okay? And of course, if you're 14 on the scale on the previous assessment, you can't get worse than a score of 14, so you would be excluded from this particular quality indicator. So that's the exclusion factors. Now these are the items. So for the communication quality indicator, you can see making self understood and ability to understand others, where 0 is that the person is understood, or they're rarely or never understood. Here you can see it's 0 is the person is independent or they understand, or here they never or rarely understand is at the top end. Notice that this one item, making self understood, is a RUGS item. It contributes to the RUG score, and it does that in the, well, we'll look at the RUGS impact in a little bit. Mood now are the E1 items, and you can see these are the ones that make up that depression rating scale. Notice that again it goes from 0 to 2. 0 indicator not present, 2 indicator of this type exhibited daily or almost daily, okay? So you can see right here that up to 5 days a week, you can see that you would score a 1. Here you'll score them a 2. All right, and if you look at the 7 different items, that's where we get the score, maximum score 14, 2 times 7. Now the next quality indicators that we're looking at are related to behaviors, and these are the behavioral items that we're interested in. And again, you can see it goes from 0 to 3, where the behavior is exhibited at a 3 on a daily basis, or here the behavior is not exhibited, the person's independent for the behavioral scale. All right, so those are the items that are used in the calculation and the sections on the MDS. So now the actual calculation for communication, we're going to calculate 2 different scores, and we're looking at the previous communication assessment, and we take the making self understood and we add that to understanding others to get a maximum score of 6 and a minimum score of 0, where you're independent. We also take the current assessment And we're going to add up the same 2 items, again, to get 0 to 6 on that scale. And so here where we're calculating worsened, of course, if your current score is greater than your previous score, then you're going to trigger this particular indicator. So, and that's the worsened. Okay, you've had a decline. For the improvement part, obviously the reverse. If the current communication is less than the previous communication score, then you've obviously improved. You've gone from 6 to a 5 or 6 to a 3, whatever that happens to be. All right, so very, very simple calculations. With the mood item, you can see once again we're showing the 7 mood items. We're just going to add them all up. So that's where we get the mood scale, and we look at the previous assessment and add up those 7 items. We look at the current assessment and add up the 7 items. And again, if your current depression rating scale is greater than your previous scale, okay, then you've declined or worsened. So again, fairly straightforward. And then on the behaviors, we have 2 different calculations to do, one for worsened, one for improved. And here, the summing up is a little bit different. If your previous score is greater than, right, if you've triggered here on the worsened scale where your score is higher, then you're going to get 1 point. If you're also exhibited more verbal abuse, you're going to get another point. All physical abuse, you get another point. And then here you can see for disruptive behaviors, you're going to get another point. So this scale can go from 0 to 4. Okay, that's looking at previous assessments. On the current assessment, we take the same 4 items and give you 1 point for each factor. All right, so that's where we come up with these 2 scores, one for the previous, one for the current. And if your current behavioral score is greater than your previous score, then you've worsened. For the improvement, if your current behavioral score is less than your previous behavior score, then that indicates that there's been an improvement. So we've looked at the actual calculation, what items are involved, what's been excluded from the analysis, and now we need to look at the RAPs. So here's where we make a care plan decision. If we trigger a RAP around communication, you can either not trigger the RAP or trigger the RAP. So this is just an on-off situation. We're using items dealing with hearing, making self-understood, and ability to understand others. Again, I'm not too thrilled with these items. I mean, the RAPs are a bit too sensitive. I believe that too many people trigger them. They're not really defining or specific enough in their calculation. However, you can see that if hearing is anything but independent, or making self understood is any score but independent, which would be 0, or C6, ability to understand, is any score but independent, then you've triggered the RAP. Else, the RAP is not triggered and no care plan decision is required. If we look at the behavioral RAP, you can see we're using the exact same items again that make up the quality indicator. So wandering, verbal, physical, inappropriate, resisting care. We're adding in this one item here, E5, change in symptoms. Remember, this is when you look back and say 90 days ago, what level of behaviors were being exhibited. And today, what level of behaviors are being exhibited. And then you're going to ask the question, has there been no change? Have they deteriorated or have they improved? And so those are the 0, 1, and 2 scale. And once again, you can see all these ORs. So any one of these factors will cause the RAP to trigger. And again, if you can see for the first one on wandering, anything but independent will cause it to trigger. or verbal abuse. Anything but independent will cause it to trigger, all the way through to E5, where if the person's deteriorated since 90 days ago, that will also cause it to trigger. So any one of these items or all of them will cause a trigger, else it does not trigger. Now, when we're looking at the RAP for mood, you can see here we have all of the items from A to P. So all of those items are included, as well as E2, which is mood persistence. And remember, mood persistence question asks if the person has in the last 7 days experienced any of these items, were they easy to resolve or they could not be easily resolved. So very, very simple or straightforward. Notice that it's triggered if any one or all of these items is not independent. Notice there's no zero score here. Okay, so if any one or all of them are not independent, then the mood RAP is triggered. Quite straightforward. And now we're on to the caps for those of you in other provinces, or if you're in Ontario and you're currently using the caps, you can see there's also a cap for communication, just like there was a RAP. Here we're going to be looking at 3 possible outcomes. It's not triggered. It's triggered where there's a real potential for improvement for a person. They actually could become more communicative. Or you can see here it's triggered in order to prevent a person from getting worse or declining. And we're using decision making this time, which is new. We didn't see that with the RAPs. We're going to look at coma, but it's not really part of the trigger in the sense that a person in a coma won't be included in the analysis. Making self-understood and ability to understand others, which we've seen before. Okay. And once again, you can notice that it won't trigger if the person's in a coma. B1 is equal to 1. Now, all these other conditions look at the case where the person's not in a coma, B1 equal to 0. And then you can see decision making. It's a 0 or 1. Remember, decision making is 0, 1, 2, or 3. So this person can make decisions. This variable called understood, it comes from adding up C4 and C6. Remember, understanding and being understood. And if the person's greater than or equal to a 2 on that scale, and that tells us if you're at the higher end of disability. And decision making is a 2. So you can see there's moderate problems for decision making. They're not severe problems for decision making. Okay, and if this variable called, now you can see this one is an and. You have to be fairly able for decision making, but you have problem understanding. That will trigger those 2 conditions. Or decision making is moderately a problem, but understanding is a much greater problem. Then you're going to be a 1, which means potential for improvement there. The other situation is where we want to prevent decline. And again, you can see here if decision making is a 2, moderate, but your understanding is fairly good, that's 0, 1, or B4 is severe and understanding is not maxed out, it's a 3 or less, so it's not up to the 6 score. And then you'll trigger a 2, you can prevent decline. Okay. So that's how the cap is calculated out on that. The behavioral cap, again, is very similar to the RAP that we saw. We create 2 new variables, which have a maximum score of 5 each. This is for daily behavioral problems, and this is less than daily behavioral problems. Okay, and you'll get a score on both of those. And then we're just going to use that same combination. It's not triggered. It's triggered to prevent behaviors from occurring daily, triggered to reduce the occurrence of daily behaviors. Okay? And you can see we're just using a combination of these 2 new variables in order to calculate that. The mood cap, again, looks at individuals who either are medium risk or they're high risk. Now, all we're going to do is add up the E1 items, these 7 E1 items. Remember the depression rating scale? And we can get a score that goes from 0 to 14. And from this one, if the person's in a coma, then they're not going to calculate the RAP. It's not triggered. If the depression rating scale is equal to 0, then it's not triggered. So there's no depression to worry about. Now, if your depression rating scale is a 1 or a 2, that means very, very high ability in that area. So depression is not a big factor. And you can see it's medium risk. However, if your depression rating scale is a 3 up to 14, then you're going to trigger at a 2 and the person's considered high risk. All right, now from a RUGS point of view, you can see that the E1 items that we looked at, the mood items, impact the complex care group. And notice that signs of depression this is 3 or more signs of depression. And this one here, and there are 16 different signs of depression altogether from E1. If you have 3 or more, you go this branch. If you have less than 3, then you go this branch here. Notice that based on your ADL score, and you remember the ADL index goes up to 18, and it starts a low score of 4, meaning you're independent for bed, eating, toileting, and transfer. But look at how many levels of funding you go up. 12 levels of funding just because of the ADL score and because you have 3 or more of those E1 items. Okay, so that's where the E1 items on this quality indicator do impact the funding model, and a very, very important one, given that nearly 20% of your residents will fall in this group, this complex group. You can see that that's a significant increase in funding if we're counting those 3 or more of those 16 different areas. Now, a C4 item, only the C4 item from the communication quality indicator impacts the RUGs. And that's the one is the understand, right? And we can see that that does that because this item C4 is part of the CPS scale, the cognitive performance scale. So, and you can see here that you would go into the cognitive group if your cognitive performance score was greater than or equal to 3, and C4 is one of the items that make up that CPS scale. Okay, and then the E4 behavioral items also impact funding levels, and of course through the behaviors. Okay, so once again, we've seen how the model is put together for funding and other things. If you haven't downloaded the most recent slide, please go and do it again. You might have an old one. Notice that I've put the 106 items. I've listed them all out here that make up the RUGS funding model. I've also added references and some other indicators for you as well. Okay, so again, any questions, leave the questions here and Heidi will forward them to me. And I will send an email out to everybody if there are any questions and answer them. Please remember to join the RAI forum. I'm not getting a lot of traffic there, so I would sure like to see a lot more input from you. And also see there's a lot of material up there that are very, very handy for working with RUGs, quality indicators, the RAPs, care planning, all of those types of things. So that's the forum called the rai.to. Thank you, everyone, and we'll talk to you again next week. Bye-bye.